Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. Today, I have the great pleasure of having on the podcast Dr. Stephanie Gill, University of Toronto, Department of Gynecologic Oncology in Toronto, Canada. And we're going to talk about a really great article titled Indocyanin Green Fluorescence Angiography for Bowel Anastomosis Assessment in Ovarian Cancer Surgery. Dr. Stephanie Gill was one of the fellows in the International Journal. We're extremely proud to have you back now as an author in a podcast. You really took great leadership in putting together this manuscript. I want to again congratulate all of the co-authors who were former fellows of the journal. And of course, obviously, full disclosure, I'm one of the authors of the manuscript. But again, really fantastic work, Stephanie. Great to have you on the podcast. Thank you for accepting our invitation and really, again, impressive work.
Thank you. Thank you so much. I'm so excited to be here today. It's really quite an honor to be able to publish this as well as discuss it with you today.
Awesome. So, Stephanie, let's get started by discussing why do you consider that this manuscript addresses an important question today in gynecologic oncology?
Yeah, so I think that's a great starting point. Bowel resections are really quite common during ovarian cancer cytoreduction, as we all know. And while our anastomotic leak rates are much lower than what's reported in the colorectal literature, I think that the impact of a leak in this patient population is enormous. So when a complication happens, it can mean prolonged hospital stays, delayed initiation of chemotherapy, infections, reoperation, and really can have a significant effect on the quality of life for the patient. So yet, despite all this, we traditionally assess perfusion as really a subjective way. We rely on visual cues, palpitation, peristalsis, and like all of this really varies from surgeon to surgeon. And we aren't really particularly accurate of determining who will develop a leak. So the question of whether ICG fluorescein can help us make safer, more informed anastomoses and surgical decisions in our patient population is really important. It has a potential to reduce complications that really matter deeply to patients. It can improve efficacy and outcomes for surgeons and even reduce healthcare costs. But the truth is, Pedro, it's never really been rigorously evaluated in gynae oncology. And this evidence gap is exactly what really motivated this review.
Excellent. Great introduction to the topic. And I want to actually ask you about two key trials that you mentioned in your manuscript before we get into the details of this particular article. But you talk about the results of the Pillar 3 and the Avoid trials. How should this frame the context of this current review?
Yeah, so briefly, the results of the Pillar 3 and Avoid were really interesting and honestly, I think a bit surprising to many surgeons. Both trials showed that even though ICG fluorescein provided clear visualization of perfusion, it didn't actually reduce anastomotic leak when used routinely. So, first with the Pillar 3, this was a multi-center US trial looking at low anterior resections, and they defined this as an anastomosis within 10 centimeters of the anal verge. And they randomized patients to ICG assessment versus a standard assessment, which essentially meant conventional visual and mechanical evaluation of perfusion. And across 25 centers, they were able to accrue 347 patients, and leak rates were almost identical. So 9% in the ICG group and 9.6% in the standard group. And the p value is only 0.37, so not statistically significant. But I do want to point out the nuance here that the study was underpowered, and the authors actually acknowledged that they did not have the sample size needed to detect a clinically meaningful difference. So that's the first thing I'll point out for that study. And then the Avoid trial. So this was a larger Dutch phase 3 trial that had 931 patients. And there are a few reasons why this is less applicable to us as well. It was exclusively minimally invasive surgery, so laparoscopy and robotics, which is a very different context from the open cytoreduction that most ovarian cancer patients undergo. 52% of this cohort was male, which of course we don't see in our field. And the study also included a mix of benign and malignant cases, again, very different from the complex oncological resections we perform. In the Avoid trial, leak rates were 7% in the fluorescein guided group and 9% with conventional assessment. And again, there was no significant difference. So I think that this context is really important. These colorectal trials are informative, but the patient populations, the disease biology, and the surgical environment are not directly comparable to advanced ovarian cancer cell reduction. So cleaner resections, no peritoneal disease, different comorbidities, it's not really a one-to-one translation for me. So to me, these
Excellent.
trials really highlight two key points though. ICG is a strong imaging tool, but its ability to prevent leaks universally is still unproven. So I really think that this frames cautious interpretation as we apply this literature to gyne oncology.
Yeah, and thank you for reviewing that because I know that many gynecologic oncologists may not be familiar with these important trials and I think again it's really important information, but as you mentioned, not really directly applicable to gynecologic oncology. And we're going to talk a little bit more about the trials that are specifically addressing patients in gynecologic oncology in a little bit in this podcast. Now, Stephanie, for the listeners who may not be as familiar. What is indocyanine green angiography and how does it work?
So ICG is a fluorescent dye that we inject intravenously. So it binds to plasma proteins and circulates quickly. And then when we shine near infrared light on the organ of interest, it emits a bright green signal. So we have specialized cameras that pick up the signal in real time, which likely on the screen in front of us. It's safe, it clears quickly through the liver, and it has been used in medicine for decades, actually.
Excellent. So, um, how is it actually used to evaluate the anastomotic integrity? You talked a little bit about its use in this setting, obviously, but like how specifically can a surgeon use this to confirm that integrity?
So I think in general, most surgeons kind of use a two-step assessment. So after you've made your resection, so your bowel resection, but before making the anastomosis or finalizing the anastomosis, you ask your anesthesia colleagues to inject ICG peripherally, and then you can check the proximal stump to ensure good circumferential perfusion. And then if it's not well perfused, then you can make decision to re-resect. After the anastomosis, then the second step, sorry, after the anastomosis is completed, you can either use a rigid proctoscope or visualize transabdominally to make sure the completed anastomotic ring is evenly fluorescent. If not, you may revise or make a decision to create a diverting ileostomy. So that's kind of the way the two steps that surgeons often use to actually evaluate the integrity of the anastomosis.
Excellent. So, as you mentioned before, a lot of this data must be from colorectal surgery. I'm sure lots of it retrospective, and you talked about prospective studies. Can you give us an overview of where we are today as it pertains to the colorectal surgery in terms of using this technology? How frequently is it being used, and is it part of the standard today for colorectal surgeons?
Right. So, not being a colorectal surgeon, but having looked through the literature quite in depth, I will say that the literature is enormous. And honestly, the findings are quite mixed. So, in our review, we summarized six large randomized or controlled studies, and they really span the spectrum of colorectal surgery. So, briefly, the FLAG study showed a significant benefit, but only for low colorectal anastomoses. The Essential study showed a benefit in minimally invasive rectal cancer surgery. And as I mentioned previously, the pillar three avoid, but then in addition, the ICG coloral also showed no significant reduction in leaks. At the individual study level, I will say the results are quite inconsistent. But what I did find really interesting in doing this review is that when you look at the meta-analysis data, we actually found two large meta-analyses and both supported the use of ICGFA in colorectal surgery. So one saw anastomotic leak reduction in rectal cancer cases from 13.9% down to 9% with a significant p-value. And then the second meta-analysis found that across all colorectal cases, the leak rates were 4.1% with ICGFA compared to 9% in the controls. And again, a significant p-value. So I think even though individual trials vary, which is likely because of differences in anastomotic locations, the mixes of cases, and the different techniques, the aggregate data painted a more favorable picture. So to me, I think the take-home message is that ICGFA clearly influences surgical decision-making in colorectal surgery, and there may be a real signal of benefit, especially in higher risk rectal anastomoses, but its ability to consistently prevent leaks seems to depend heavily on anastomotic location, patient factors, and case selection. So it's not a universally protective tool at this point. And I will say, from what I have heard, and if there's any colorectal surgeons out there listening, they can correct me, but I think it's used in the same way it's used in gynecology, that it depends on the surgeon in the center.
Excellent. Yeah, and don't you just love it when there's so much variance in terms of the results of the literature, and you're still wondering, of course, how do we move forward? And so we get actually on to some of the questions from our fellows, and you remember actually posing some of these questions, so some of them can be challenging at times. So we'll start with Masha Pervin from the University Hospital, Münster, Germany. And as a follow-up to your last point, she's asking, of course, obviously now we have all of this data from colorectal surgery, but how do we move forward evaluating this in gynecologic oncology?
Yeah, so I love seeing these questions because they do put a lot of thought into them and they are really quite thought provoking. So, for this question, though, I really think we need our own studies. So, there is a lot we can learn from the colorectal literature, but as I've mentioned, the surgical environment is fundamentally different. So, in ovarian cancer cytoreduction, our patients typically haven't had pelvic radiation and they have a wider and more compliant pelvis, being all females. And the disease biology is completely different. So we are often working in a setting of peritoneal carcinomatosis, inflammation, or after neoadjuvant chemotherapy. And we must point out too that our leak rates in gynae oncology are actually already quite low or much lower. And the type of anastomosis we perform don't always mirror the colorectal practice.
Mm.
So while some principles will translate, I think we can't just completely import that literature like I had mentioned. And I think to make things more challenging, studying this properly in gynecology is difficult because, like I said, the outcomes that we care about, like anastomotic leaks, are fortunately quite rare. So that means you need a very large sample size to detect meaningful differences, which is difficult for a single center or even a small group of centers to accomplish. But I think that's exactly why trials like the ARIA 2 are so important. We do need rigorous multi-center gynecologic oncology specific data to understand when and where ICGFA might actually benefit our patients.
Yeah, and definitely we're gonna speak a little bit more about that trial in a few minutes. ETV Agraf from Spain, she's asking, why specifically do you think that leak rates are so much lower in gynecologic oncology? You alluded to some of these reasons before, but can you expand a little bit on that?
Yeah, so I really think that there are three key reasons. The first being female anatomy. So, as I mentioned, the pelvis is wider and considered more compliant. And as I had mentioned, a lot of the colorectal studies had half male participants, and they actually have been noted to have higher leak rates due to their anatomy alone. So, we do have an easier working space and less tension often when we are making our anastomoses. The second thing is there's no or minimal preoperative pelvic radiation. So, for especially in ovarian cancer cases, it's very unlikely or less likely to have pelvic radiation, unlike rectal cancers, where majority, or I don't know if I can say majority, but I would say at least 50% of their patients do have pelvic radiation prior to surgery, which does change things from a surgical perspective. And then the third thing is that we have different more comorbidity profiles and tissue characteristics from the actual disease process itself. So these three things I think are the key reasons why we have lower leak rates altogether. And even in multiple bowel resections we have in the literature. So if someone needs to do multiple bowel resections in their ovarian cancer patients, the median leak rate is still below 7%, which is much lower than colorectal surgery, which has been reported up to 19% in some studies. So I think those three reasons help us achieve such a lower leak rate.
Great. This next question comes from Mathilde Del in Toulouse, in France. An important question. And of course, obviously, we hear many surgeons saying, well, I never had problems and I don't need this technology. Her question is, what are the traditional methods surgeons are using to assess anastomotic viability? And what do we say to a surgeon, particularly in gynecologic oncology, that says, I've been doing this all my life without this. Why do I need to assess now using this technology?
Yeah, I think that's a great question and something I've thought a lot about, especially being early in my career. But I will say that traditionally surgeons rely on a subjective set of tools to assess anastomotic viability. Many people still do the air leak test, but they also consider a combination of things like visual inspection. So what we would quote as being pink and pulsatile bowel. They may look at the peristalsis, bleeding at the cut edges of your anastomosis, the tissue turgor or thickness, as well as manual palpating it manually. So I think that these things in combination have really been a backbone of surgical judgment for decades. But we do also know that they're not particularly accurate. One study is quoted that the sensitivity can be as low as 38%, and none of them really truly quantify microvascular perfusion. So I think that's the big thing is the actual blood flow and perfusion to the bowel is where we may be able to sell people on this technology moving forward. Um, I also think it's important to mention that there are also other many clinical factors that influence anastomotic integrity that surgeons think about at the time of anastomosis, regardless of what the bowel looks like in that moment. So this is things such as the overall surgical complexity, blood loss, whether the patient needs blood pressure support with pressors, their nutritional status or preoperative albumin, as well as their comorbidities. So I think all of these things can affect healing as much as what we see intraoperatively, and those things all come into play for the surgeon at the time. So to be clear, I think I don't necessarily see ICG fluorescein fully replacing these traditional assessments or the surgeon's judgment because I don't think we can fully remove that from the picture. Those are core skill sets that are always going to be essential, and I don't think should be necessarily taken away from people or made less important. But I do feel that ICG fluorescein does offer an additional objective layer of information, especially around the perfusion, which is what I was mentioning, something that our eyes and our hands can't reliably assess on their own. So I don't think it removes subjectivity entirely, but it really supplements our decision making, particularly in those borderline or high risk situations that we sometimes see ourselves in.
Yeah, excellent points. Just as an additional tool, and it's safe as well. So I think definitely to be considered. And now let's move on to a question by Mo Byrne from Memorial Sloan Kettering Cancer Center. And she's asking, across all these trials that you mentioned, which patient subgroups do you really consider that may benefit the most from ICG angiography?
So I think specifically from the randomized trials in colorectal literature, there was two patterns that consistently stood out to me. The first was having low rectal or low colorectal anastomoses. So these anastomoses sit deep in the pelvis where perfusion is more precarious and even small areas of ischemia matter. Specifically, the FLAG trial, they found the benefit of ICGFA was confined specifically to these low anastomosis within 4 to 8 centimeters of the anal verge. And higher anastomosis in those studies did not show the same advantage. So I think that's important to point out. And then the second thing that actually really was interesting in the colorectal literature is the patients that underwent minimally invasive rectal cancer surgery. So specifically the Essential trial, patients that underwent laparoscopic or robotic rectal cancer surgeries had significantly fewer leaks when they were assessed with the ICG fluorescein. So I think those two groups are the biggest that I noticed. And I will say that, especially for the minimally invasive, even though we don't do it a lot for our ovarian cancer patients, it is interesting because in those cases, the surgeons they're not actually having that additional skill set that we just talked about to assess the bowel. So in those cases, it does kind of make sense that it was more important. But yeah, I think overall, the greatest benefit is in these cases where the risk of ischemia is the highest.
Okay. This next question comes from Sanito Marin in Mexico. And he's asking, your review mentions that experts disagree on what, quote, adequate perfusion looks like. Why is interpretation still so subjective?
So I think this is a great question because it gets to one of the biggest limitations of ICG fluorescein right now. We simply just don't have clear guidelines or rules that define what adequate perfusion looks like. So at the moment, this is largely based on surgeon's judgment. And even though ICG fluorescein gives us real-time fluorescein signals, there is no standardized threshold for what counts as being fast enough uptake, bright enough intensity, or a complete circumferential pattern. And the interpretation can be influenced by a lot of technical variables. So things to consider, such as camera distance and angle, the ambient light in the operating room, edema or inflammation of the bowel, the dose of ICG and the timing of injection, and then differences between imaging systems. So because all of these things, two two experienced surgeons could watch the same fluorescein pattern and interpret it slightly differently. It's not because the technology is flawed. I think it's because we don't yet have validated quantitative criteria to really anchor those decisions. So right now, I think defining good perfusion is ultimately up to the surgeon, which does introduce some variability. So as we move forward, I think quantitative perfusion mapping and AI-assisted interpretation could potentially be involved at some point to get a standardized objective threshold that we currently lack.
Excellent. So now we'll move on to two questions from someone you know well, Joanne Nouveau from Newfoundland, St. John. And first question is, given that anastomotic leaks in gynecologic oncology are already rare, 5 to 7%, do you believe ICG angiography meaningfully reduces this risk, or are we solving a problem that it's already quite rare?
Yeah, so this is a great question. I mean, yes, our leak rates are low in the range of 5 to 7% and have even been reported as being lower in high volume centers. So the absolute benefit we could expect from any intervention is naturally smaller compared to if there was a larger problem. But even with that in mind, I do think that there is still potential value. An anastomotic leak in ovarian cancer patients has major consequences, as I had mentioned earlier. So, delayed chemotherapy, prolonged hospitalization, infections, reoperation, and a real impact on overall recovery and quality of life. So, even a 1 to 2% absolute reduction could still be meaningful for the patients. And I think the honest answer, though, is that we don't yet know if ICG fluorescein meaningfully will reduce this risk in our population. As we've said, our current data is limited to small observational studies, and they do show that ICG fluorescein is safe and feasible, and we can change intraoperative decision making, but they're not powered to detect differences in leak rates because the event is so rare. So again, it kind of brings up, I think that's why the trial like ARIA 2 is so important. It's if ICG fluorescein is going to move to a promising tool to standard practice in gynae oncology, we do need the high quality evidence to show how it changes. So in my view, yes, I think it does reduce the risk, but I do still think we need rigorous data to prove it. And until then, I think selective and thoughtful use does make sense.
Excellent. So this next question again from Johnny, and I knew this question would be coming. How do you envision integrating fluorescence imaging with artificial intelligence to overcome the subjectivity that currently limits reproducibility? Could this finally transform it into a truly evidence-based tool rather than just a visual impression? Before AI-driven perfusion mapping can change practice, what kind of validation would you consider convincing? Prospective trials, standardized thresholds, or just real-time outcome correlation? Always easy questions from Johnny.
No. Well, I'll see if I can answer all of those questions in this, but I really think AI is really exciting frontier here because one of the biggest limitations of ICG fluorescein right now is the subjectivity of interpretation, like we mentioned. So if we could pair fluorescein imaging with AI, we could move towards truly quantitative, reproducible perfusion assessments. So I think in theory, AI could evaluate things like time to peak fluorescein, intensity curves, regional perfusion gradients, and even subtle patterns our eyes may miss. And then they would translate that information into real-time objective metrics. But I think there's a big practical hurdle in gynecologic oncology. So as I've mentioned, because our anastomotic leak rates are so low, generating the massive data set needed to train and validate AI models is extremely challenging. AI needs thousands and sometimes tens of thousands of labeled examples to learn what a good versus unsafe anastomosis would look like. And with leak rates already being rare events in our population, the learning curve would become very steep for this AI model. We're already seeing the early stages of what this could look like, though, because I have seen a recent multi-center transatlantic study in colorectal surgery, and they developed a deep learning model that analyzed intraoperative video frames to predict anastomotic leaks. The model reached 99% accuracy, which I think is actually really extraordinary, and even generated heat maps showing which part of the anastomosis influenced its prediction. So this study had one major advantage. I think colorectal rates are much higher, meaning they had enough positive cases to train the algorithm. And like I said, I think that would be much harder in ovarian cancer surgery. Not impossible, but harder. And I think would require quite a large group of multi-centers to participate. But what I really think is that meaningful validation would be three things. You would need prospective trials where AI generated perfusion metrics are compared with real postoperative outcomes. Two, you would need standardized protocols. So this would consist of dosing, timing, camera distance, and imaging platforms so that AI isn't learning the noise in the background. You need to really control the setting. And the third thing is you really need to define your threshold where certain perfusion parameters correlate with a clinically meaningful increase in leak risk. Meaning some things are not clinically meaningful. If we scanned every patient after surgery and they had an abscess, does it really matter if they're not symptomatic? So I think defining those thresholds is really important. And I think if we can achieve that, then yes, AI definitely has potential to transform ICG fluorescein from a visually interpreted tool into a truly evidence-based quantitative decision support system.
Excellent. Now, this next question is about patient selection. It's from Matteo Lovero in the Policlinico Gemelli in Rome. And he says, given the conflicting results across trials, do you think part of the issue is that ICG fluorescence has often been used without a clear selection criteria? Would we benefit from a more structured algorithm to identify which anastomoses actually require perfusion assessment? Such stratification might also improve the cost effectiveness of this technique.
So yeah, I think this is a really insightful question because yes, a big part of the variability we see across studies probably comes from the fact that ICG fluorescein has often been used without clear selection criteria. So in many of the colorectal trials, every anastomosis was assessed with ICG regardless of risk. And so when you apply any intervention universally, including to very low risk cases, the observed benefit does get diluted. In gynecology, we probably would see something similar. So our bowel resections vary widely in complexity from short, healthy sigmoid resections to long rectosigmoid resections deep in the pelvis. Not all anastomoses carry the same risk, yet ICG fluorescein is often used based on surgeon preference rather than a structured risk-informed approach. So to answer this question, I do think a more systematic or selected algorithm could help. Um, but that being said, I also recognize the practical reality of it that once a center has invested in the technology and the upfront cost is already absorbed, using it routinely doesn't add much in terms of time or ongoing cost. So for surgeons who use it in every case and really like using it, it may actually be difficult to convince them to stop using it or to switch to a more selective algorithm.
Mm.
But I do think that's why having evidence-based validated selection criteria could be helpful. It allows to move from a more individual preference to a more standardized outcome-driven approach without really relying solely on habit or availability.
Great. And another question from Mateo is often, well, which of those that you mentioned is the most important if there's one? And he's asking, consideration of the factors that influence the interpretation of ICG fluorescence, like camera distance, dosing, tissue characteristics. What do you think could help us improve the objectivity of perfusion assessment? In other words, do you think any one of these is more critical than the others?
So I have touched on it already in this podcast, but I do think that there's several factors that influence how we interpret it. So improving objectivity really starts with standardizing the way we acquire the signals in the first place. So to summarize, a few practical steps that could potentially make a big difference is standardizing the dose of ICG and timing of injection, controlling camera distance, angle, and lighting, using quantitative overlays or perfusion maps, capturing dynamic measures and not just snapshots, and moving towards automated or AI assisted interpretation. Now, out of all of those, I don't necessarily know which would make the biggest difference. I think it is, it's hard to say because we haven't studied any of them individually. So when you look at all of them in
Yeah.
together to pick which one would be the best, but I think even starting with the simple things like standardizing ICG dose and timing of injection, like those are simple things that we could see. Do those make a difference? So in cases like this, starting with some of the easier things to change might be the best starting point, and then see if those make a difference. And if they don't, then you escalate it to the more complicated um, depth. So controlling camera distance, angle, and lighting can be pretty difficult when you have thousands of operating theaters that you'd have to implement this in. I think that would be quite challenging. So I think to answer this question, do I know which one would actually be the best? No, but I think starting with the easiest first and escalating would be a good way to start.
Yeah. Stephanie, this next question comes from Paulo Mateo, yeah, at Houston Methodist. It's more a question about what do you do yourself? So she's asking, it seems there's still quite a bit of controversy surrounding the evidence in gynecologic oncology. Until we have the results of the ARIA trial, this uncertainty will probably remain. So, what do you do in your institution? Do you use ICG fluorescence today for anastomosis in your GYN cases?
So we do. I have the pleasure of working at two different centers here, and both centers do use ICG fluorescein angiography for assessment of bowel anastomosis. I will say the use does vary from surgeon to surgeon, but I would say the majority of cases that involving a rectal sigmoid resection, and even sometimes for small bowel resections, especially if multiple resections in one case, we do use the ICG for assessment. I will say that the indications in our center are not standardized. It's not that we have some secret protocol we're keeping from everybody, but we do use it in the majority of our cases. I did a little bit of a poll for different staff that I work with, and a lot of them again brought up the ARIA 2 trial and really interested to hear the results of that so that we can make it more standardized. But I say in everyday use, most of our surgeons do use it as an additional data point. But not as the sole decision maker. So for us, it's often a nice reassurance when things go well. So if an anastomosis is straightforward and the fluorescein looks great, it reinforces that we already felt based on our traditional assessment. But at this point, I will say the ICG fluorescein is not enough to override the clinical judgment of our staff, our surgeons. So, for example, if the patient had high blood loss requiring pressure support, low albumin, or technically challenging case, I still would say that we're very cautious in fully hanging our hat on the ICG. And for us right now, it is still a full kind of clinical decision.
Okay. Stephanie, this I'll go to a question by Carlotta Sabini from Milan, Italy. And she's asking a bit more about the learning curve. And she's asking, should ICG fluorescence already become routine for all surgeons, or should we be spending a little bit more time on the learning curve and the safety of this approach? And do you have a sense as to after how many cases do you finally feel that you are really able to perform this approach?
Mm-hmm. So I think this is a great question because it really gets at how we should think about ICG fluorescein. Is it a universal tool or is it something that particularly valuable during training or early practice? And I actually think the answer is both, but for different reasons. So for surgeons in training, ICG fluorescein is incredibly valuable. I think trainees are still developing their intraoperative judgment, their ability to assess bowel quality, tension, perfusion, and the feel of the anastomosis. So the ICG fluorescein provides an objective reference point that helps reinforce or challenge what they were seeing with their naked eye. I think it essentially acts like a real-time teaching tool. So this looks well perfused, and here's the fluorescein to confirm it. Or this area feels borderline, and look, it actually slow to enhance. I think it accelerates learning in a way that traditional teaching alone simply can't. Um, and then on the flip side, for experienced surgeons, I think the value is different. So most high volume surgeons have excellent judgment and perform safe anastomoses without ICG. But even for them, the ICG fluorescein can provide reassurance in difficult cases, a second check when the case is borderline, and a safety net in situations with risk factors like I have mentioned, low albumin, high blood loss, pressor use, etc. So I don't think it's replacing their judgments; it's augmenting it. So great question, but I really think that there is benefit for both groups.
Yeah. So, Stephanie, I want to be respectful of your time, and I really so much enjoyed this discussion. So, we're going to go to our last question. And since you were a fellow, we've now integrated a new feature of the podcast where we actually submit your article to AI and then ask AI to give us a question about your article. So, Your question from AI is, how do the authors reconcile the strong industry and institutional investment in fluorescence platform with the absence of any cost effectiveness data in ovarian cancer and the weak or negative trial data? Does this represent evidence-based adoption or technology-driven inertia?
So I think that we have to acknowledge that fluorescein platforms weren't bought for bowel anastomoses, which I don't think the AI maybe knew. Maybe it did. But I think most centers have invested in them for a whole range of reasons. So, as we know, sentinel lymph node mapping, some centers would have it for hepatobiliary surgery, urology, or ureteric identification, robotic systems that often come with it built in. And then the ICG fluorescein for anastomotic assessments became a logical next use. So, in many places, what looks like adoption driven by weak data is actually, in my opinion, repurposing technology that's already there. So once that upfront cost is sunk, the marginal cost and time per case are actually low, and there's a natural tendency to use it broadly, even before we have watertight evidence for its use. Um, but I think at the same time, we don't have cost effectiveness data in ovarian cancer, which I think would be a really great next step in this. And some of the larger randomized trials in colorectal surgery have been neutral. So if a hospital is considering buying an expensive fluorescein platform purely to reduce anastomotic leaks inside reductive surgery, I say that that's ahead of the evidence and wouldn't recommend it. But to me, this isn't pure technology driven inertia. It's more technology driven enthusiasm that now
Mhm.
puts the responsibility back on us to generate the data. And that's again, I think ARIA 2 is doing that. They exist precisely because the technology has outpaced the gynecological oncology specific evidence, and we need to close the gap in that rigorous way. So I think how do I reconcile it? I think I'm comfortable with centers that already have these platforms using ICG fluorescein as an adjunct, especially in high risk cases. I think I'm less comfortable with the idea of major new capital purchases justified solely by anastomotic perfusion without clear outcome or cost effectiveness data in our population. So I hope nobody has read the article and gone out and bought a machine based purely on that. And then I also see it as part of our job to make sure this doesn't stop at just these cool images, but progresses to evidence-based indication-focused use. So this includes being willing to accept a negative trial if that's what the data ultimately shows. So I think in other words, the technology isn't the problem. The issue is whether we're disciplined enough to let the evidence and not just the availability shape how we use it going forward.
Excellent. So, Stephanie Gill, thank you so much for your time. Really, really enjoyed this discussion, learned so much. And again, congratulations for your leadership in bringing this manuscript forward. Again, very impressive work. And thank you for what you have done. And again, for your leadership already very early in your academic and professional career. Thank you for being also a role model to many others.
Thank you. Yes, it was great to be here. It was really fun. So hopefully I'll be back soon.